all of them. So the way to say it's between the moderators and the three of you. So it's my pleasure to welcome all of you to this our 11th session, which is dedicated to mostly rare disease and pediatric neurology. This particular session has been dedicated to channelopathies. We welcome Dr. Satyendra Aneja, who's, as we said, one of the pioneer founding members of pediatric neurology in India, and who's known to all of us here. Which was founder member, director and professor head in LHMC, Lady Harinj, and currently working as professor of pediatrics in Noida, Sharda University, and has done she's done multiple peer-reviewed journals, national and international journals. Madam, on to you as well as Dr. Sahu. As I mentioned, Dr. Sahu is currently in an academic institution. He's the additional professor in PGI, Chandigarh, which is one of the premier institutions in the country, and has research interest in developmental and epileptic encephalopathy with West syndrome and Draves. And he's also the recipient of multiple awards, Bernard D'Souza Award and Ehsan Drogmoch Award and Sheila Wallace Award and Dr. H.P. Dingley Award, with multiple publications to both their credits. And I'm handing it over to both of you. Thanks to AOCN, our Indian Association of Child Neurology, as well as ORDI, which is a parent support organization that does a lot of work in trying to create awareness to bring this coming together and sharing of knowledge. Thank you.
So thank you, Anne. It's a pleasure to be here and great to be here amongst such accomplished neurologists. And I must congratulate AOCN and you for taking this initiative, for really, doing this, having such great talks over several weeks now. And I'm so happy to be amongst you and happy to see how our AOCN has grown, and how you people are contributing. So as a senior member, I really feel very proud of you all. And very nice to be here and amongst such galaxy of speakers who are such, experts in their fields. So I will, can I start with the first speaker, or Jitendra, shall I start with you first, that you wanted to say something?
Yeah, just thanks, Dr. Anne, for a very beautiful initiative, this rare diseases webinar series. And today's theme is very, very enticing, and we have very eminent speakers. Yes, yes, ma'am, please.
So I think as Jitendra is also working in this field, so I think it's doubly good for him. For his working, I can see that on some genetics on, I think Draves also. Jitendra, am I right?
Yes, yes.
Yes, so I think it should be very interesting for you also. So, so our first speaker is Dr. Andreas Brunclass, and he is a consultant pediatric neurologist in Royal Hospital of Children for Glasgow, and also senior lecturer there. He has been trained in Germany and in Great Ormond Street Children's Hospital, and also from Royal Hospital for Children, Glasgow. And he has interest is mainly ion channelopathies, especially sodium channelopathies, and of course, he's a leading expert in Draves syndrome. In fact, I think he has lots of studies on Draves syndrome, and especially on the quality of life, I think, which is extremely important for all of us here. So it's very interesting to see, and I would really looking forward to his disease-modifying gene-based therapies for Draves syndrome. I think that is really something which is we're looking forward to. So we'd love to hear from you. And as I already said, he has plenty of publications, more than 50 on channelopathies. So it's lovely to interact with you. And I think all of us have some patients, and it's really looking forward to your perspective and your newer therapies for Draves syndrome. So over to you, Dr. Andreas.
So, Dr. thank you so much, and thank you so much for reaching out and for inviting me to speak. And let me just share my screen. It's a real pleasure to have these initiatives, and to really also to reconnect to some of you who I might have met in Glasgow or while I was working at Ormond Street Hospital. And can I just, I'm just going to share this. Can you all see this slide?
Yeah, we can see it.
Perfect, good. So we've got half an hour where we'll really focus on some of the biological, the clinical and treatment aspects and neuronal sodium channelopathies. And I like the whole disease biology aspect because that helps us to understand how these diseases actually emerge and also how to treat them. And so I really start with voltage-gated sodium channels. So what are they? So we have, but now we've got 9 voltage-gated sodium channels, and they're vital for functioning of excitable tissue across the nervous system, but also in heart and muscle. So this is not just about epilepsy. This is also lots of what I'm going to talk to you about today as well applies to other sodium channels as well. They've got a role in generation of action potentials. They regulate voltage-gated sodium channel activation, and what we know, they're mainly localized in cell bodies. And we know that the distinct channel expression profile is really specific to each channel. And it all starts with the action potential. So this is really the famous work by Hodgkin and Huxley in 1952, when they looked at the giant squid axon and really were able to show that you have this all or nothing response of the action potential that you will all remember from your medical school days. And the sodium channels are really important because here you can see how you've got the resting potential, and then you have this sudden influx of voltage-gated sodium channels opening and depolarizing the membrane. So that's really, really important. And you can imagine if that's not working properly, then you end up with a lot of problems. And the sodium channel alpha subunit is really quite similar for all the different sodium channels. And you have, so these are ion channels that sit in the cell membrane, and they have got 4 homologous domains. So the whole amino acid is about 2,000 amino acids. The whole protein is 2,000 amino acids long, and you've got this 4 homologous domains, and each of them have got a voltage sensor and a pore, and then they form together, these 4 domains form together the channel, and the ions travel through here, through the pore, and you've got this voltage sensor that picks up the current across the membrane, which then allows the pore to open and the sodium ions to travel through. And you can then later we talk about certain functional consequences of, for example, if a channel can't open, you might get loss of function, or it can't close and you get gain of function. And so this is a whole family of channels. And I've here listed in dark gray those that are actually expressed in the central nervous system. So that's SCN1A, causing Dravet syndrome, GEFS+, but also early onset epileptic encephalopathies, then SCN2A, causing epilepsy, but also autism spectrum disorder, SCN3A, causing epilepsy and brain malformations, and then SCN8A, causing epilepsy and different forms of epilepsy and intellectual disability. But here you can see, for example, SCN4A, expressed in muscle, responsible for myotonias, then SCN5A, expressed in cardiac myocytes and causing Brugada syndrome or long QT, and then SCN9, 10, and 11A, and you will have come across this in your inherited pain disorders in SCN9A, and then also in SCN10 and 11A in the peripheral neuropathies. And lots of the concepts that we're going to talk about today really apply to all of these sodium channels. So let's talk first about the SCN1A related phenotype. So that's really one of the first phenotypes associated with epilepsy as a monogenic epilepsy. And we had this report in 2000 about mutations in the SCN1A gene encoding the sodium channel and being found in 2 families with genetic epilepsy with febrile seizures plus. And then very briefly afterwards, that was in 2001, Lieve Klaas and Peter de Jonge from Antwerp really described de novo mutations in the SCN1A gene causing severe myoclonic epilepsy of infancy, or now Dravet syndrome. And this is Charlotte Dravet, who described this in the 70s in Marseille in France, and then it became really apparent that all children with Dravet syndrome carry the SCN1A gene variant. And more recently, then 2005, we had, interestingly, mutations in the SCN1A gene associated with familial hemiplegic migraine, and what we know, it's a different disease mechanism. So where GEFS+ and Dravet syndrome is a loss of function mechanism, where the familial hemiplegic migraine is a gain of function mechanism. And then finally, we have quite recently, so Lynette Sadler and Ingrid Scheffer from Australia and New Zealand. So they described that not all SCN1A epileptic encephalopathies are actually Dravet syndrome, and they described this cohort of about 8 or 10 patients with this threonine 226 methionine phenotype with an early presentation movement disorder. And then there was some work done on this to show that these are actually also a different mechanism. It's a mixed gain and loss of function causing this distinct phenotype. And if you go back to the core Dravet syndrome phenotype, so these are children that present in the first year of life with febrile seizures, and they're often prolonged, unilateral, or generalized clonic seizures. And then from the first year onwards, we have other seizure types like myoclonic seizures, atypical absences emerging. And what is characteristic that most of these children, when you first meet them, when they're infants, you think they're developmentally normal. But what happens then really within the first few years of life, it becomes very apparent that there's lots of comorbidities and developmental disability. And this really becomes apparent after the first year of life, and ultimately resulting in a developmental and epileptic encephalopathy in most children. And that's still the case now. Even with the treatments that we have had over the last 10 years, we still see that actually this disease trajectory hasn't really changed. And there's an entire spectrum of SCN1A related epilepsies. And on the mild end, we've got the genetic epilepsy with febrile seizures plus or GEPS plus, or also febrile seizures plus. And on the severe end, we have Dravet syndrome. So when we looked at this over 10 years ago now, so this is my original MD work that I did with my colleague, Professor Samir Zuberi. So we had a cohort of 241 individuals with SCN1A mutation positive Dravet syndrome from the United Kingdom and also some international cohorts. And we then estimated how common this actually is. And we looked at a specific UK birth cohort of 88 patients from 2003 to 2007, because we were, in Glasgow was the only center at the time to really test for SCN1A in the United Kingdom. So we thought that we would capture everybody. And then we thought it would be 1 in 40,000. But actually now my colleagues, so Joe Simmons and Samir Zuberi published this really nice paper in Brain a couple of years ago now on the incidence and phenotypes of childhood onset genetic epilepsies, a prospective population-based national cohort study. I really recommend you. It's open access. You can easily access this. It's very interesting because you can really see how frequent the different types of monogenic epilepsies are. That's based on a gene panel of 104 genes, and every single child in Scotland presenting with epilepsy in the first 3 years of life was tested. And you can see here the most frequent, you can see that SCN1A is one of the most frequent monogenic epilepsies. And now we know, because we really captured the entire Scottish population, that the incidence here is 1 in 15,500. So Dravet syndrome is much more common than we initially thought. And here, just to think about where's the SCN1 gene actually expressed? But I mentioned earlier that all these diseases present according all these diseases or mutations in sodium channel genes will present according to where the gene is actually expressed. So you can actually, this is a very nice website. It's called the GTEx portal. And again, that's open access. You can just access this, and then you can type in whichever gene of interest you have, and then it basically gives you an overview where in the body this particular gene is actually most expressed. And that's really interesting. So here, for example, so when you type in SCN1A, what you can see is that this is mainly expressed in the brain. Yeah, so this is all human tissue, but you can see this is mainly expressed in the brain, and it's expressed in the frontal cortex, it's expressed in the hippocampus, in the cortex. So it's really nice to see where different genes are expressed, because that's where you expect to have most impact. But what you can see here, clearly, it's not just expressed in the hippocampus, it's actually expressed in the cerebellum as well. So, and I think that leads us to the concept when we think about Dravet syndrome, that this is really a channelopathy, Yeah, so it doesn't cause just epilepsy, actually it causes a lot of different problems. And so a good example is so this is work that's been shown by you et al. This is Cattrall's group in Seattle, and they really were the pioneers in showing that what is the deficiencies that the SCM1A gene is expressed in inhibitory interneurons. And if your inhibitory interneurons are non-functional, your excitatory neurons take over and you get too much excitation and epilepsy. And this is, for example, this is expressed, and this was in mice in the hippocampus. So if you've got too much expression, you've got, so if you haven't got any inhibitory interneurons, you've got too much excitation and you end up with epilepsy. But we know also that the SCM1A gene is also expressed in the cerebellum. So in the cerebellar Purkinje cells. So if they are not working, if there's a loss of function in them as well, you actually then present with increasing ataxia and movement disorder. Yeah, and this is one of the phenotypes that we see in Dravet syndrome. And what's really important is that this is expressed in the frontal cortex. And this is work done on mice again here. So for example, on the top left, these are mice, the wild type mice and Dravet mice. And what you can see here is how active they are. And you can see that the Dravet mice, they're much more hyperactive, which is a proxy for ADHD really in mice and in humans. We know that ADHD features are really prominent in Dravet kids. I've got one patient who is so hyperactive. It is really, so he can, as he's now 3, he comes into my clinic room and he cannot sit still. He's all over the place. Yeah, so you can clearly see that this is a phenotype associated with Dravet syndrome. And then these mice were treated, and you can see how actually that improved their phenotype. Then mice are very interactive animals, and they like to hang out with each other. And here, what you can see here is that actually Dravet mice, compared to wild type mice, are much less interactive. Yeah, so this is almost a form of showing that mice, autistic features in mice. And this is something that we also see in Dravet syndrome, that children with Dravet syndrome have a number of autistic features. And that is really because the SCM1A gene is also expressed in the prefrontal cortex. And what's interesting here, the last example here at the bottom is an experiment where there was a targeted downregulation of SCM1A in mice. These mice did not have seizures, but presented with spatial recognition deficits. And that's the first proof of concept that it's not primarily the seizures that are driving the entire phenotype. It's actually the underlying channelopathy that's driving all these difficulties, presenting with seizures, movement disorder, and cognitive deficits. And that's really important, of course, if you think of future treatments, and particularly gene therapy approaches. So if you look at different variant classes, so how do these mutations present? So we've got 50% are truncating variants. So in truncating variants, we know this leads to complete loss of protein function, and you would expect to have a severe phenotype because 50% of your sodium channels just don't work because there's loss of function. For the missense variants, that's slightly different. So that's again 50%, but there we don't know whether this leads to a complete loss of function or whether there might be some residual function. And you can see that if you look at all the GEFS plus patients, so genetic epilepsy with febrile seizures plus patients, they will often have missense variants and not truncating variants. So if you then look, so you send your gene panel or genetic investigations, then you get a result back, and then you need to decide whether your variant is significant. And so what your genetic colleagues will tell you, so if it's a truncating variant, they will say this is loss of function and therefore often significant. However, if you've got a missense variant, it all depends on, so is it de novo in the patient or is it inherited? If it's inherited, it's less likely to be significant. Does it affect a functionally important protein part? Is it conserved in different species? What is the difference in the amino acid composition? Are there any functional data available? And is it present in population databases, which would mean that it would be less significant. And there's a number of in silico tools that your laboratory colleagues will use, but they're just a guide, but often they're not so helpful. They're helpful in deciding between if it's pathogenic or not pathogenic, but not really cannot tell you how pathogenic this is. And so if you hear look, for example, at the different neurodevelopmental disorders associated with sodium channel defects. So here, particularly the brain expressed ones, so SCN1A, 2A, 3A, and 8A. And this is from ClinVar. This is a database that's publicly available where you can actually look up whether certain variants have been reported in the past. So you find a new variant and you want to look up, so has this been reported in the past, to gather some more evidence. And what you can see is, there's what I highlighted here is really there's quite a number of uncertain variants of uncertain significance in ClinVar, and we still struggle to classify certain variants as are they really pathogenic or they're not pathogenic. So it's just an illustration that our methods at the moment are not particularly sophisticated to really call all the variants and be confident that these are pathogenic. And so here it's really just an illustration that for missense variants, so how do missense variants from the general population differ from those found in patients? So you have to remember that you will have lots of polymorphisms. And what you can see at the bottom, just to explain this graph, at the bottom you can see basically the structure of the protein. Yeah, so you've got the four homologous domains, and you've got these big intracellular loops. So this is where this is the representation of the protein. And here you've got the number of missense variants reported in the general population. And of course, I could carry an SCN1A variant, a missense variant, if it's in a region of the protein that's not important. For example, here, I will have no disease. Yeah, because it's a missense variant that doesn't do anything. So we have lots of missense variants that are what we call polymorphisms. They happen in normal individuals and they do not present with disease. Yeah. So what you can see here is that all these polymorphisms cluster in these areas that are not really important for protein function. And here I show you what happens to the disease-causing missense variants. So you can see here that the disease-causing missense variants, they're really clustered along these areas where there's important functional aspects of the protein. Yeah, so we know that missense variants really indicate and are more common in areas of functional importance of the protein. And this has been used by Eduardo Perez Palma and Dennis Lal and their team. So this is a really interesting website. So I put the details here. This is called the PER viewer. So basically it's the same principle. So what they've done is they've really compared all the different sodium channels together as a family and determined which areas of the protein are actually important. Yeah. So, and again, so if you think about this is the 2000 amino acids, and then you've got these the four homologous domains. And what they've plotted here is all the nomad variants. So these are all population variants. And then these are the disease variants here. Yeah. So, and it's a tool this is from the same tool. So this website allows you to basically look up the SCN1A or the sodium channel genes. And what it does, it lines them up one next to the other. So SCN1A, 2A, 3A, 4A, they're all lined up next to each other. And it tells you in which gene at this position you've actually find disease. Yeah. So this is a nice tool that allows you to, if you find, for example, a new variant, and you look at this tool, and then you can find, okay, at this position, has disease been reported at the same position in other sodium channels? Because they're also related. It gives you an idea that certain defects at a similar position in a different gene can really help you to identify whether there might be disease or there might not be disease. Yeah, so I recommend you, if you work with genes, to actually look at this and explore that. And so what we did, we then looked at really all the functionally characterized sodium channels. So the SCN1A experiments. So I told you, I mean, there's thousands of SCN1A variants reported. But when we looked, that was 2 years ago, only 50 or 60 of them had actually been functionally characterized. And the difficulty is, if you do actually a laboratory experiment to see what the currents actually are for sodium channel, it's really laborious. It takes over 6 to 12 months to do this. So we only have a small number that are actually functionally characterized. So we collected them all and then looked what their function is like. And what you can see here, this is again the protein structure of the sodium SCN1A protein. And here, all those variants that had Dravet syndrome in red, those that had milder phenotypes, so Dravet syndrome or GEFS plus in orange, then those variants that had familial hemiplegic migraine in blue, and then this is the early epileptic encephalopathy case. What you can see here, they're clustered all in these homologous domains. What we then did, we then looked at whether there was any correlation with the genotype and the functional readouts that we have. So we look basically, whenever you look at the function of a sodium channel, you want to see, is there actually a current? So a normal sodium channel should mount a current, a Holzer current, as a marker of function. Yeah. So, and if there's a current, then you know the channel is working. If there's no current, then you know the channel is just not working at all. Yeah. So basically what we looked at here was there a measurable Holzer current? If there wasn't a current, this was marked in red. If there was a current, it was marked in blue. And here we looked at the severe phenotypes. These are Dravet syndrome only, and here at the milder phenotypes. And what you can see is that in the severe phenotypes, the proportion where there was no current at all was much higher compared to the milder phenotypes, where actually quite a number of these individuals, when you looked at their channels were still functional. Yeah. So what you can see is, what we draw from this is that even among missense variants, it appears that in missense variants that are really, really severe, resulting in loss of function, they're associated with Dravet syndrome only. Whereas actually, if you've got a GAS plus or febrile seizure plus patient with a missense variant, often they have residual sodium channel function, and that's why they don't present with such a severe phenotype. And this is a really nice tool from Henrike Heine and her group, and this is published last year in Science Translational Medicine, and this is a tool that allows the prediction of functional effects of missense variants in voltage-gated and calcium channels. So it's really important is voltage-gated and calcium channels are almost identical in their structure, and this is a really nice tool there where you can look at and see how so you can actually use this, and if you've got a new variant, you can actually put this in and then estimate whether this is a likely loss of function or gain of function variant. Okay, so now moving on to the other sodium channel genes. So for example, here SCN2A related disorders. So here we've got, it's a very nice work by Marcus Wolf, 4 main groups. We've got the benign familial neonatal infantile seizures. We've got the encephalopathy with early onset epilepsy at less than 3 months of age, resulting in Ohtahara syndrome. And then we've got the encephalopathy with older, over 3 months of age onset, and then resulting in West syndrome and Lennox-Gastaut. And then we've got the ones with intellectual disability without epilepsy. And what we know is, so from the benign neonatal infantile seizures, these tend to be all inherited. All of them are missense gain of function, and they all respond to sodium channel blockers, and they're just milder phenotypes because they're inherited. What we know about the early onset epileptic encephalopathy, so the really severe phenotypes, they're all de novo. Yeah, so they're not inherited, and they tend to be gain of function. And for example, you might have a gain of function because the channel cannot close, so you get too much firing of the neuron, you get a gain of function, and then and these individuals respond to sodium channel blockers, and that's an SCN2A. Then in the late onset epileptic encephalopathies and autism spectrum disorder, so these tend to be loss of function SCN2A variants. Yeah, these are in patients with later infantile onset epilepsy and loss of function due to, so the channel cannot open, and you have not enough firing on the neuron, loss of function, and here, of course, sodium channel blockers do not work. This is now SCN8A encephalopathy, and here very similarly, so you have the phenotypes of the very severe developmental epileptic encephalopathy, and then you've got the intermediate phenotype and a small proportion of benign familial infantile seizures. And if you look at the functional work here, again, so you've got a wild type here, and here you've got a gain of function effect, and the epilepsy variants are mainly gain of function, and these individuals respond to sodium channel blockers. Often you have to give really high doses of sodium channel blockers. And lastly, SCN3A, this has been recently reported as a spectrum of epilepsy and brain malformation. What's really important here, SCN3A is a neonatal form of the sodium channels, so that's really highly expressed in utero, and you might speculate why this might have an impact also on brain malformation and brain formation. So again, and these tend to be gain of function variants, and they tend to respond to sodium channel blockers, and these children present really, really early in the first days of life. So this is just a summary slide of a publication I wrote with my collaborator Dennis Lal in DevMed last year, and really looking at, so in summary, looking at SCN1A presenting with Dravet syndrome and GEPS plus, presents an infant, it presents around 6 months with loss of function variants and response to benzodiazepines, valproate, stiripentol, fenfluramine, cannabidiol, and you shouldn't give carbamazepine. Then SCN2A, the early onset, less than 3 months, presents with gain of function. You can treat with carbamazepine. The later onset, after 3 months, often loss of function. And SCN3A presents prenatally at 2 weeks, gain of function, again, treat with carbamazepine. SCN8A presents a little bit later, gain of function, and to treat with carbamazepine. You might wonder why all these diseases present at different ages, and I think that's explained by their gene expression profile. So what you can see here is, at which time in the child's development these genes are actually mainly expressed, so either prenatal, infant to childhood, older or adults. What you can see here, SCN1A is not expressed early on, but the expression starts in infancy and then later on. SCN2A is expressed very early on and it remains expressed. SCN3A is expressed early on, but then the expression drops. And then SCN8A the expression rises. So what you can see here is that particularly SCN2A and 3A, they present in the neonatal period because they're expressed much more than the others. And we looked at this and we published this in Epilepsia last year, where we actually looked at the gene expression strength. So you've got the genes here, then you've got the expression strength according to age, from 0 to 6 years. And you can see, and then we plotted that against the seizure onset. So basically for SCN3A, expression was very high early on and they presented very early and then it dropped. SCN2A, you had expression also from early on. SCN8A, expression was not high early on, but increased later, and your seizure onset was also later. SCN1A, the same, expression early on wasn't great, but then actually increased expression and the presentation was later. And really, if you think about a model of sodium channel disorders, so you've got this model of early onset seizures, either due to less inhibition, and that is because you have basically a loss of SCN1A function, and if you've got a loss of SCN1A function, then you've got more excitation because you don't have your inhibition, and then leading to epilepsy. However, if you've got a gain of function SCN2, 3, or 8A, you get more excitation leading to epilepsy. And if you have late onset seizures and neurodevelopmental disorders, basically what you have less excitation due to a loss of function SCN2, 3, or 8A, leading them not necessarily to epilepsy, but to neurodevelopmental disorders and later onset epilepsy as well. So I think what's important is here is just to appreciate the concept of mosaicism. So whenever you have in genetic testing, I think it's a common pitfall that we now know is that you can have up to 7.5% of all patients might have there might be mosaicism. And that's really important. If you sometimes can't explain the phenotype, you can't really explain why it is a milder phenotype or a more severe phenotype. So it's worthwhile looking for mosaicism, and new advances in genetic techniques can do that. And the appropriate treatment is really important. Yeah, so this is work by Iris de Lange et al. From Utrecht in the Netherlands, and they looked at how patients, for example, with SCN1A variants have been treated. And if they received sodium channel blockers in the first year of life for prolonged periods, their developmental outcome in the end was worse compared to those who were not treated with sodium channel blockers. So sodium channel blockers in Dravet syndrome are contraindicated, and it's really important to make an early diagnosis to make sure that you don't treat children with Dravet syndrome with sodium channel blockers. The problem is that children often present with febrile hemiclonic seizures. So because they're hemiclonic, people think, oh, this might be a focal epilepsy, and let's start treating with sodium channel blockers. But actually, these are children who present with febrile hemiclonic seizures and status. So be careful on those kids. So in terms of evidence of treatments, so we've had stiripentol in 2000. We've been using for the last really 10-15 years. Then we've had cannabidiol. It's now being used since 2017. The trial was then fenfluramine, in 2019, and now our treatment algorithm for Dravet syndrome really is changing. So often valproate and then clobazam together with stiripento, but then we have cannabidiol and fluoramine and other doses of bromide. We use that in Glasgow a lot, but in Germany they use it a lot. You know, so I think this is all changing due to new evidence, and this is really, I think. So all the monogenic disorders, of course, lend themselves to gene therapy. And this is really where I think we're heading for Dravet syndrome. So in the United States, Stoke Therapeutics have started the first program of antisense oligonucleotide treatment in Dravet syndrome. So patients have been recruited since last year. Then there's another company called Encoder Therapeutics. So they're have been working on an engineered transcription factor to upregulate SCM1A expression in GABAergic cells, and the trials for that will start early next year. So clearly there's a lot of movement now in terms of gene therapy trials going forward. The mouse model work all looks very encouraging. So this is really something very exciting for the near future. And so I would like to conclude that so voltage-gated sodium channel disorders present really according to the severity of the underlying gene defect, whether you've got a truncating or missense variant, whether it's a gain or loss of function, then that the symptoms and comorbidities are closely linked to the distribution of the gene defect across neuronal networks, so where these sodium channels are mainly expressed. Then we know that the heterogeneity is often explained by variant-specific gene expression, timing, and function, and that sodium channel variant characteristics can contribute to clinical decision making. And finally, I would really like to thank our team. So this is our team in Glasgow. So there's a very Joe Simmons, our geneticist, and then our international and national collaborators. And that brings me to the end of my talk. And I think we're going to take questions at the end. Is that right? Thank you
for a very brilliant talk. You very beautifully summarized the advances of the Dravet syndrome in a very short span. Splendid data of your work. Ma'am Maneja, you want to say something?
No, I think we have already exceeded time. So it was a lovely hearing you, and it was a very comprehensive, starting from biology, from the lab to the bench side. I think it was very comprehensive, and we are very happy to hear that talk. I think we will have lots of questions at the end. Thank you, Dr. Andreas.
So now we invite Dr. Murugan Velayuthan. It is privileged to invite him. He is MBBS alumnus of from Thanjavur Medical College. Can we have a CV slide? So he did his MD Pediatrics from Indore Medical College. He is Royal College Fellow. Currently, he is consultant pediatric neurologist at Birmingham Children's Hospital, and he is also senior lecturer in Birmingham University. He is chair of West Midlands Pediatric Neurology Forum. His subspecialty interest is movement disorders, and he has more than 25 scientific publications. And he is going to speak on a very important topic, that is genetics in migraine. This is it's very interesting topic, and it's a pleasure to invite you, Dr. Murugan.
Can you see the slide?
Yes, it is fine, perfectly fine.
Okay, thank you. Thank you very much for the kind introduction, and thank you for the AOC and ORDI for inviting me for this talk, and particular thanks to Dr. Anne Agnes Matthew. I think when I got this invitation, I was going backwards in my career that when it comes to migraine, there is a clear gap exists among the pediatric neurologists in terms of understanding, in the clinical diagnosis of migraine. That includes me also till date. And when I was reading for this presentation, I have learned even more what I know already. And from there, my talks comes from. Only I got 3 genes to talk about. Andreas have very detailed, in-depth. We talked about the sodium channel. I think the next talk by Dr. Samantha going to be another gene. So I'm left with only 1 gene to talk about. So essentially, very little to talk about the 3 genes I have. So what I'm going to focus on is how to make use of our clinical approach to make a genetic or familial hemiplegic migraine. And the real knowledge came in the form of expanding the horizon, meaning the migraine at the center, but you come to start diagnosing overlapping conditions which carry the same gene which causes the familial hemiplegic migraine. Let me start with a couple of cases I had after I had my training in Southampton 12 years ago. This is a 9-year-old girl who traveled from Trivandrum to Mumbai, Mumbai to Gulf, Gulf to Southampton, or even before Southampton to Manchester. So 5 different cities. Mom is an intensive care nurse. So imagine somebody is working in intensive care. This child is going through episodes of weakness in either right or left hemiparesis, and with the background of global delay ataxia, and no definite diagnosis was made. And that made her to kind of literally worried about her daughter all the time. And when she was in a nursing shift, you can imagine, because being an episodic episode, she will end up in the hospital at any time. Such a long delay can happen in children with hemiplegic migraine if you don't think about it. So that's where this presentation is going to address on from now on. And she had one of the MRI showed mild cerebellar atrophy also. And she also presented with migraine with aura time to time. But because her neurodisability on the background, on top of that, this is happening, she was kind of not diagnosed for a very long time. The next child, 14-year-old boy, and he came to me in the outpatient clinic with a global delay. Subsequently, learning difficulty became the main problem. And he also showed some autistic spectrum disorder features. He was presenting with episodes of ataxia. Then he was demonstrating that parents kindly showed me the video, a very tremulous movement affecting his right arm when he experienced these episodes. And these episodes were happening for 6 years. And there was a history of migraine, which was there. But these episodes were very distressing for him. Because of the, again, the disability he has, I think this was not attended to in normal neurology child. We normally extensively investigate, find the answer. I'll come to both the cases, what happened at the end. So let us start with the clinical diagnosis of migraine. So I think there are many types described. I don't need to go into that in the learned audience like today. So I will particularly focus on the one with migraine with aura, which is relevant to the topic of today. So there is a very clear definition or clear criteria outlined by the International Classification of Headache Disorders, and there are 3 editions already happened. The one on the right, you can see that to diagnose migraine with a typical aura, one should experience at least 2 attacks of headache with aura. In the aura could be visual, sensory, speech symptoms, but that should not include any motor, brainstem, or retinal symptoms. And the aura, what are the key features of that? So the aura should be lasting less than 60 minutes. The headache should follow along with aura or within 60 minutes. And at least one aura should be unilateral symptom. And then the symptoms can happen one after another. So these are the features when you ask the history to go specifically, because the diagnosis might be starting from here itself without you are considering an investigation on children who present like this. So this is a very common one where you have migraine without aura, migraine with aura. Why that aura association matters here? Because there are so many variants we see here in migraine. I'm not going into the detail, just to overview of where it lies. So this is a paper from Bulgaria, and what they did was about close to 2,500 patients, out of which they had 111 children with migraine. And you can see in that cohort, only about 4% of them got familial or sporadic hemiplegic migraine. What's the difference? We'll be talking about it in a minute. So that is a kind of just to give idea, but the population study quotes very less. This is a tertiary center study. Naturally, the incidence will be higher. And but still, why bother in such a low percentage of patient population in normal practice? For two key reasons. These children end up as acute emergency, neurological emergency sometime. These children, when they turn up to neurology, it will force you to investigate extensively if you miss the clues they have. And that's where this condition matters in day-to-day neurology practice. Let us move to the next one, familial and the genetic nature of the migraine. We all know that no history of neurology goes without anybody with headaches asking about the family history of headache. So what does it mean? We know it is a polygenic inheritance or a familial condition, but that inheritance alone is not enough to manifest migraine in general population, because you need to have a trigger from the environment for the migraine to manifest. That's why you would have somebody presenting at a childhood, somebody presenting at a teenage age, somebody presenting in adulthood. So that is kind of well known. And what we know, the other category is the monogenic inheritance. That's where the rest of the talk is heading towards, where the familial hemiplegic migraine, we got the linkage studies, genetic linkage studies clearly proved there are 3 genes exist, which directly link to the hemiplegic migraine they are experiencing. So here again, how does it fit in the definition of channelopathy? Any channel dysfunction can be inherited or acquired. This causes the disease, make the either overactivity or underactivity of the tissue concerned. Most of the time, it is a highly excitable or tissues like nerves, muscle, or heart gets involved. So here it is the brain, and they have a nature of presenting as a paroxysmal disorders. So when you see the next few slides, you would see familial hemiplegic migraine fit this bill as a channelopathy. So, but this was long time discovered, but very little progress in identifying more genes. We'll come to that in a minute. So not only this condition, you can see that there are other channelopathies. As a neurologist, you all aware about it. I don't need to go into detail. And they have overlap each other. That's one thing to remember. As a neurologist, we always walk with, as though, imagine like Rajinikanth walking in this movie with a lot of tools. That any child turn up, I have lots of tools, I'll throw one, if it doesn't work, I go to the next. So that's how we do it all the time. But we can get it wrong if you do that approach here. But rather, you have to use very minimal approach here. But I took out the image from the train track, if you remember this movie, where he had very little in terms of any tools actually. So in this movie, for example, he was using the tape recorder to get to know the earth or world. So like that, as the clinicians, we have journals and books, and that's what is needed when you approach a child with migraine or any variant of migraine. Because if you go into the investigation route, and sometimes you will keep on going in the track, but you may not reach the destination. So let us go to the clinical diagnosis of familial hemiplegic migraine. So ICHD again came in the clear criteria. We have 3 criteria. at least 2 attacks fulfilling the criteria of migraine with aura, then motor deficit, predominantly the hemiparesis which happens, should be reversible. There should be a family history, either 1st degree or 2nd degree. But what is the nature of the familial hemiplegic migraine? So it's autosomal dominant condition. Permanent neurological deficit is very, very rare. And some children can take weeks, sometimes months to recover from it, but usually they will recover. Like what the patient I showed, every episode, she will take 6 to 9 months to get her on her feet really. That level she goes. She becomes very ataxic, hemiplegic. She needs 6 to 9 months before she goes back, meaning walking independently to school. So that is a key parameters here when you look at it. And so the weakness resolved between the attacks. So moving forward, what are the 3 genes? First one, which was discovered very early, 96, I think. So CAGNA1 gene is a calcium channel. And this gene always overlap with other condition you can see on the right, overlap with the ataxia and epilepsy. The few patients I have come across, they have a background of developmental delay, coordination problem, or ataxia, clear-cut ataxia. On top of that, they would experience an episode of weakness, hemiparesis, and that's how they give a clue. So it's very common in neurology practice to see these children, but at the moment they develop the hemiparesis, and one should think about this condition before asking for a genetic test. So it has a tendency to overlap. The classic example is episodic ataxia type 2 and the spinocerebellar ataxia type 6, which I rarely see, but I have seen episodic ataxia type 2. Why these entity matters? Some of the medication we can use can make it better. Again, I'll come back to that later. So, and this is where these learning about these genes help in neurology practice, that you expand horizontally, not thinking about the condition associated with the gene. There may be overlap, you may be dealing with some other condition also in these children. The type 2 is ATP1A2 gene, and again that comes with the variable presentation, and our next speaker going to talk about in detail about alternating hemiplegia of childhood. I'm not going into that, but it can present with epilepsy, and even without epilepsy, even standalone seizures can be there. These children can have a permanent mental retardation on the background. There could be a periodic paralysis going on in these children. And very characteristically, some children, but luckily it is rare, they can present with coma. So anybody unexplained encephalopathy, think about hemiplegic migraine. All the 3 mutations cause, but out of the 3, this is one can cause more often. And so each one comes with many, many variants. So the third variety, already we heard a lot about sodium channel mutation from Andreas. So that is a other one we got. Then, so essentially all these 3 genes have a kind of or affecting the ion channel and typically fulfilling the channelopathy based on that. So now, having heard about the familial one, where you are supposed to have a family history. If you don't have a family history, then automatically, but their presentation is exactly same except the family history, they fall into the category of sporadic hemiplegic migraine. So that is where you can still ask for the genetic panel for migraine or hemiplegic migraine, but the yield is less compared to the family history one, meaning the familial hemiplegic migraine. So, and that is one you would come across when there is no family history. So in the general population, approximately 1/3 of cases can be sporadic, and ATP1A2 is very common in a sporadic group. There's one author who described where in those children, when the mutation was negative, the phenotype is milder, meaning under the subheading of sporadic hemiplegic migraine. This comment in one of the article I read might be useful in Indian context, and we may not be able to get the genetic studies for all the children. So they conclude in their paper where our patients with familial hemiplegic migraine were not genetically tested because of the lack of this test in Bulgaria, but they were classified as familial hemiplegic migraine because more than one member of the family members suffered with it. So that is a key clue. So when there is a hemiplegic migraine in the family, if you are seeing a child with hemiplegic migraine, so even if you don't have the mutation, you are dealing with a child which is already diagnosed really. So it has been many, many years. You can see from one mutation to another, there is a clear gap when these mutations were discovered, but not much progress happened in the sense that compared to epilepsy, not many genes are identified. And so I think, but these genes at least clearly says many phenotypes leading to one gene or many genes are presenting with one phenotype is very clearly expressed in familial hemiplegic migraine. So with that knowledge, if you go in terms of expanding these genes or overlapping conditions, there are a few conditions one should look out for. One is episodic ataxia, I mentioned earlier. Spinocerebellar ataxia for Cagna1A, I have talked about it briefly earlier. But the key thing is that if you look at the bottom half of the slide, the movement disorder in PRRT2 and PNKD and GLUT1 transport defect, these children are prone for hemiplegic migraine. So even if they survive the early years without significant epilepsy or movement disorder, these children can present with hemiplegic migraine. So if you go back into the history, parents would have not bothered about the abnormal movements the child experienced or one-off seizure the child had, which is very common in PRRT2 mutation. The epilepsy is not that severe. A lot of children, they can grow out of it as they become older. But that's how they come to the neurology attention sometimes. Why? These are the conditions you can sometimes treat better if you know the etiology. As you all know that ketogenic diet can make so much better for GLUT1, PRRT2 mutation. A small dose of carbamazepine not only fix the epilepsy, it can fix the abnormal movements or a movement disorder. It can make the migraine also better. So that's where you are expanding or the crossover symptomatology of these children. The next one is the three vasculopathy mutation. The first one is CADASIL, predominantly adult disease, but still it can happen in children with the NOTCH3 mutation. So these children, before they present with stroke, there will be a clear history of migraine with aura. A lot of time that gives a clue. So for example, somebody presented with the first time stroke, it doesn't fit with the normal stroke we see in our daily practice. If there is a family history of migraine, if there is a family or a history of migraine in the child, it is giving clue to us identify these genes. The same thing can happen with collagen 4A1, collagen 4A2. The TREX mutation for RVCL can happen as well. So now these are the two conditions I'm going to talk about very briefly. And this is a very challenging in neurology practice. Somebody presented with encephalopathic way, and then there may be weakness there. But when you do the MR, you kind of come to know there is some cerebral edema, what to do. This is the first presentation and suspect this condition, particularly if there is a history of migraine in the background in the family. So these cerebral edema, they tend to disappear. So this is more for the trainees, but this is basically all the three. This is one paper with 3 patients. All of them had cerebral edema affecting the left hemisphere. Basically, the sulci you are seeing on the right side, which is more of a streaky lines, they are all sulci pattern that all disappear on the right side. Sorry, left side you can see. Left side there is no sulci you can prominently see compared to the right, meaning because of the cerebral edema. These children end up sitting in the ward with encephalopathy, very slow recovery. hemiplegia will stay as long as the whole symptom stays. That includes fever, that includes unconsciousness, that includes dysarthria and other symptoms. So slowly they will make the recovery. After a few months, these edema disappear, as well as neurologically the child get back to normal. So when you do the mutation, but in that paper, out of the 3 they got there, all the 3 were, I think, sporadic, but 2 of them got a mutation, 1 didn't. So the next one is that when you have a history of ataxia, developmental delay, and the episodes like this at different ages, and the seizures or epilepsy is coming and going, minor head trauma is one of the trigger for a hemiplegic migraine. So when you get a story, every time the child had minor head trauma, the child end up in the hospital with hemiplegia and much more symptoms, neurological symptoms, and suspect this. And these children sometimes can show cerebellar atrophy. So anybody with the developmental delay, on top of that, they are showing cerebellar atrophy, they may not experience the hemiplegic migraine very early on. The moment they are experiencing, you strongly suspect this condition. And some of them can be made better using some of the channelopathy medication. That's why you have to be aware about it. Not only that, otherwise you may end up investigating this child every time. This child had about 4 or 5 episodes from the age of 8, 13, 14, 15. And imagine if they have to go through investigation again and again, like the list as it says here, blood and cerebrospinal investigation and echocardiography, and a lot of EEGs happened. And the MRI on this child was first time it was normal. At age 8 and 13, you can see the cerebellar atrophy. And and this child was found to have CACNA1 mutation. And the parents were not showing any mutation. So that completes the kind of diagnostic picture. But earlier, the awareness about this condition, this child could have been diagnosed very early on. So that's where the literature is advocating us to suspect this condition before. So I talked about my patient earlier, where there is no family history, and this child was identified with CACNA1 mutation. I got the history from mother that when she was on phenytoin, she had a long interval. So I chose to continue the phenytoin. Actually, that prolonged the interval, meaning without any episodes for many years afterwards. So I haven't tried many drugs, but for somehow the phenytoin worked for her, and as a channelopathy medication. So, and at least mom was happy that she got an answer what's going on. I think it's very common in parents to go through doctors not able to tell us what's happening with the child. The next child, and because of the episode nature, episodic ataxia was first thing in my mind. I put him on acetazolamide. Within weeks, he completely stopped getting these episodes. Somebody was experiencing almost on a weekly regime. So again, it is a hit and miss. I would not advocate for everybody this works. It depends on, it works, otherwise you have to change it or try something else. So there are few medications tried differently, depends on where you practice. Acetazolamide is one of them, verapamil is one, and I have seen a paper saying people trying methylprednisolone, at least during the encephalopathic or comatose phase. As I said, PRRT2 mutation, when you suspect that, carbamazepine is one, and GLUT1 diagnosed ketogenic diet can help. You always treat them symptomatically to treat their seizures and symptoms control, like pain relief, things like that. Theoretically, it's better to avoid triptans in familial hemiplegic migraine. One of the key trigger in these children is head trauma, minor head trauma, and somebody's keep falling. It's better to wear a helmet so that they not end up in the hospital soon. So that is the end of my talk. Thank you for listening.
Thank you, Dr. Murugan. You very beautifully, your cases were excellent, and with the help of them, you brilliantly explained this very complex topic. So I enjoyed very much your talk, and I'm sure that there will be a lot of questions which will be taken up by end of the session, and kindly stay with us. So, ma'am, Dr. Neja, you would like to say something? So,
I think we can go to the next
okay.
because we are.
So, the next talk is on alternating hemiplegia, and it's pleasure to invite Dr. Devapam Samanta. He is MBBS alumnus from Kolkata Medical College. He did his MD Pediatrics from Maulana Azad Medical College, Delhi University. He did his Pediatric Neurology Fellowship from University of Virginia Medical Center. He did his Clinical Neurophysiology and Epilepsy Fellowship from University of Arkansas for Medical Sciences. And at same place, he is currently Associate Professor and Medical Director of Comprehensive Epilepsy Program, MAG Lab, Clinical Neurophysiology Lab, and TSC Clinic and Neurogenetics Clinic. So it's a pleasure to invite Dr. Devapam. We look forward to hearing your talk. Welcome, please.
Thank you. I'm going to share my screen now. Can you see my screen?
Yeah, that's yeah.
Okay, thank you. So I'm very excited to talk about AHC, or alternating hemiplegia of childhood, today. And I feel really honored to be invited to give this talk. Special thanks to Dr. Suhasini Sarma to reach out to me and suggest this topic. I don't have any personal disclosure relevant to this talk. My training is mainly in epilepsy, and my research interest in implementation science. But very early in my career, I had the opportunity to treat several patients with alternating hemiplegia of childhood, and that actually raised a lot of interest, clinical interest in this disorder that I'm going to talk today. One thing I want to disclose that I'm going to talk about different medication for treatment. There is no approved medication for this indication. So this discussion would be off-label use of this medication. So I have three guideposts that I want to put up that my talk would traverse through these guideposts. First, I would give some discussion and consideration how to clinically diagnose a patient with alternating hemiplegia of childhood. The second topic and second learning objective would be to review pathogenesis of AHC. And this review would be primarily to give some rationale why we choose some of the treatment options for AHC. So let's start with a patient that I have seen very early in my career. And I was coming to inpatient service, and I saw this 12-year-old who was admitted to the hospital. And she had a diagnosis of intractable epilepsy since infancy. The reason she was admitted in the hospital because she was having one of her usual episodes. That's the sign off I got from the other attending, that she was having clusters of seizures, she was quadripartic, she was encephalopathic, and she was having a lot of hyperkinetic chorioathletic movements. So she was actually not having some sort of diagnostic hallmark that we think about in alternating hemiplegia of childhood, that you would have alternating weakness. Actually, she was diagnosed with presumptive autoimmune encephalopathy based on some really low titer of autoantibody, and her MRI had shown bilateral mesial temporal sclerosis. But as I was talking to her parents, the parents described that she started to have symptoms when she was a few days old, that her eye would do something funny, that's parents' description. And then she developed seizure, and she had episodes of post-ictal torts paresis. That's the physician gave the diagnosis to her. And then she had a scoliosis surgery when she was 8 years old and developed progressive dystonia of right arm. She had gait difficulties, she was ataxic, and she had a verbal skill of 2 years old in between all her seizures at that time. So all this description did not jive well with the diagnosis of autoimmune encephalopathy. So we ended up doing whole exome sequencing with TRIO that identified ATP1A3 pathogenic mutation consistent with her clinical presentation since infancy to give her a correct diagnosis of AHC. So AHC is an ultra-rare disorder with reported incidence less than 1 in 1 million newborns. This was first described almost 50 years ago by Verret and Steele in 8 pediatric patients. And the first clinical diagnostic criteria was established almost 40 years ago in 1980, with several modifications since then, with last major modification in 1993. So we have clinical diagnostic criteria established so many years ago, but why we still having trouble clinically diagnose a patient with ASC? The one thing that this is a very, very rare disease. So there is lack of awareness, even among physician community about ASC. Second, they have significant variability of clinical presentation, as I'm going to discuss in the next slide. They have different abnormal movements. Sometimes they're very complex, and the complex movements can evolve with time. On top of that, more than 50% patients would have comorbid epilepsy, and usually physicians would have a tendency to describe or explain some of the symptoms as manifestation of seizure or post-ictal paresis rather than finding or trying to find an underlying diagnosis. Now, the diagnosis is much more straightforward now after the genetic mutation that's responsible for most cases of ASC was discovered in 2012 by 2 different research groups. Now the diagnosis and misdiagnosis is much less common, especially where there is access to genetic mutation. But still, the clinical diagnosis is very important. First, there would be places that the access to this genetic testing would not be easy. Second, there are maybe 70 to 80% of cases of AHC would have ATP1A3 mutation, but that would not explain or diagnose all cases of AHC. And third, that ATP1A3 mutation does not only cause AHC, so you need to know the clinical phenomenology of AHC because it can cause other disorders, and close to 10 different syndrome can be caused by the ATP1A3 mutation, such as rapid dystonia and Parkinsonism syndrome or Kaposi syndrome, and several others. So let's briefly talk about the diagnostic criteria for classical AHC. So the first is onset of symptoms before 18 months of age. So this is only for classic AHC, as you all know that the AHC patients can present later with atypical presentation up to 4 or even later. Then the diagnostic hallmark that they have repeated attacks of hemiplegia involving either left side of the body and right side of the body, and that can last for minutes to hours to days, even several weeks. And typical onset is around 6 to 7 months of age, but I have seen a patient presenting much earlier or later. On top of that, they can have a bilateral hemiplegia or quadriplegia, depending on arm involvement or leg involvement as predominant feature that can evolve from the hemiplegia, that they start with just one side weakness in one episode that can involve the other side, or it can start de novo. So from the beginning, they can present with quadriplegia or bilateral hemiplegia. So besides all the weakness, they can have other paroxysmal disturbances. So that's the complex or the so many different types of abnormal or paroxysmal movements come into play. They can have tonic stiffening, they can have dystonia, they can have oculomotor paroxysmal abnormalities, like the patient I described before. Just few days of life, she started to have left eye nystagmus. So monoocular nystagmus or strabismus can happen. And in a way, it's the earliest diagnostic feature of classic AHC and can point to this diagnosis very early in these patients, even before they start to have the hemiplegic attacks. They also can have autonomic phenomena, such as apnea. Their body color can change. I have one patient that the face color would change suddenly. And these episodes can happen during the hemiplegic episodes, or they can happen in isolation. One interesting feature is all these symptoms can disappear, or usually would disappear during sleeping, and they can again resume after 10 to 20 minutes of waking up. So these are all the paroxysmal features, but they also would develop some accumulating burden or fixed neurologic deficit over the period of time. They would have intellectual abnormality, they would have gait ataxia, they would have hyperkinetic movements. So these would be fixed day-to-day abnormalities besides their paroxysmal disturbances that I described before. One important thing to consider that this is an ultra-rare disease, so we need to be mindful about rule out some other common disorders. Like my previous speaker talked about familial hemiplegic migraine, Moya-Moya disease or Moya-Moya syndrome, other genetic disorder such as GLUT1 deficiency disorder, and other genetic disorders such as ATP1A2 genetic mutation. So all this clinical diagnostic criteria is very helpful, but despite presence of these criteria for close to 40 years, we struggled with misdiagnosis. But all these things change since we have the genetic mutation identified in ATP1A3. Now, where there is access, the diagnosis is straightforward, that with even some features, we can go straight to either next generation sequencing or whole exome sequencing for confirmatory diagnosis. Now, this is our learning objective number 2 today, that you can see that ATP1A3 pathogenic de novo mutation cause loss of function of alpha-3 isoform of the sodium-potassium ATPase pump. So there are 80 different type of mutation or more than that identified that cause this loss of function. And as you know, that this pump is responsible for exporting 3 sodium outside the cell to bring 2 potassium inside. So there are 3 positive ions going out in a replacement of 2 positive ions. So that maintains a slight negativity in the membrane that's important for resting membrane potential. So you have loss of function of this pump, and you deal with the subsequent so many different downstream abnormalities, signal transduction abnormalities causing AHC. But now I want to discuss some of the other hypotheses related to pathogenesis that would help with our learning objective 3 to choose some rational therapy. So first is related to calcium channel. So the calcium channel blocker frequently used in the treatment, and there is some hypothesis that in AHC, we deal with intracellular accumulation of calcium that cause cell damage and cell death. So how that happens? So there are 2 main mechanisms. One is the anti-voltage gated calcium channel that opens, causing calcium influx inside. And the other mechanism is the pathway through sodium-calcium exchanger, that sodium goes out and calcium gets in. The other important treatment option that's a recent discovery and getting popularity in AHC community is ketogenic diet. And as you can see in AHC, there is inhibition of the K-ATP channel that cause, in general, excitability. Now, lastly, I want to touch upon the imbalance between glutamate and GABA in patients with ASC. So as you know, that more than 50% patients with ASC would have, so these patients deal with hyperexcitability. So that means that they can have either increased glutamate or decreased GABA or a combination of both. So the way increased glutamate may happen is related to a co-transporter, which is co-localized with this sodium potassium ATPase pump. The name of that co-transporter is EAAT1, which is a glutamate co-transporter, brings glutamate outside, from the outside of the cell to the inside. But when the co-transporter is not working, you have increased glutamate or increased excitation. What about GABA? So what happened with this alpha-3 isomer of the sodium potassium ATPase pump is disproportionately affect GABAergic interneuron. So we are dealing with disproportionate dysfunction of the GABAergic interneuron compared to the pyramidal neurons, which are primarily glutamatergic. So with this basis of pathogenesis, let's jump into management. And the management is in a way similar that we do in terms of seizure management or migraine management. So we need to think about something acute management, that the patients, when they're having these paroxysmal episodes, what to do about those, and also choosing some therapy that would prevent of these paroxysmal events to occur. So that can be decreased frequency of these episodes or decreased severity of these episodes. So most worrisome feature, as you know, that would be these paroxysmal events lasting for minutes to days to weeks, and we don't have any disease-modifying therapy so far. So the main aim is symptomatic management currently. Now, sometimes we can identify specific trigger for these events to happen, and some of these triggers are modifiable, such as sleep deprivation, physical or mental exhaustion, or excessive stimulation. And our job as neurologists would be teach parents how to identify trigger and how to avoid those. But some of these triggers are difficult to alter, such as being sick, febrile, illness, menstrual cycle, accidental head trauma, and weather change. And in that case, we need to treat caregiver to monitor patients for potential recurrence and get the child to a low stimulation environment to try to prevent these events to happen. But despite all the attempts, these events may happen. And my current favorite for treating these patients usually would start with some sort of non-benzodiazepine sedative. That can be phenergan, diphenhydramine, melatonin, trazodone, to start some sort of non-benzodiazepine sedative at home. In some countries, chloral hydrate also has been used. We don't have access in US to have chloral hydrate. The next step would be using benzodiazepine. There is no study to prove one type of benzodiazepine superior to other. I use any and all, can be midazolam, can be clonazepam, diazepam, lorazepam. Sometimes these patients are encephalopathic during these episodes, so I need to use alternative route to administer, such as midazolam nose spray, dissolvable clonazepam tablet, or rectal diastat, razepam to use. Sometimes I'm targeting really small episodes that are less frequent but longer episode. I use a longer acting benzodiazepine. Sometimes they're having really brief episodes and they need to go back to their usual daily activity. I would choose something like midazolam. Some people use sodium oxybate, which is a narcolepsy medicine, to induce non-REM sleep. And it needs to be careful in terms of increasing sedation, that they are not eating or drinking enough, or trouble with breathing. So sometimes whatever you do, some patients would come to the hospital for more aggressive treatment. So Next, we're going to talk about some of the medication that we use for chronic prophylaxis. And I would not have time to go and discuss in detail about all the medication. So please refer to this paper I wrote a couple years ago, or last year, where I described all the medication that people have used, their dosing recommendation, what to look for, and also the evidence behind their use. And I'm going to touch upon a couple of these here. So first would be flunarizine, which is a non-selective calcium channel blocker. And it was first used because of AHC's clinical symptoms similar to familial hemiplegic migraine, which my previous speaker described is because of CACNA mutation primarily. So calcium channel blocker was used. First, it was used by Seizure and Ajuj in just one patient, followed by another patient, Dr. Kuratulo and Kusami used with remarkable and dramatic response. And there was a randomized control study that was done soon after. The randomized study was negative, but since then, thousands of patients were treated with flunarizine with good success, with more than 50% reduction in the duration and the severity of the dystonic and hemiplegic attack, and around 25% would have reduced frequency of attacks. There may be some additional benefit in eye movement abnormality, chorioathetosis, dystonia, and ataxia. One advantage that we actually don't need to know the exact mutation causing it, because the effectiveness may not vary across different mutations. There's not much long-term safety concern, but it may not prevent some of the fixed neurologic deficit that I talked about, such as intellectual impairment. The other disadvantage is not useful in the management for epilepsy, and it's difficult to access in many countries, including US, that we don't have flunarizine approved for any indication. So we need to get this medicine from other countries. Next is ketogenic diet. As I talked about, KATP channel activation, and this is my current favorite. So far, the evidence for use is limited compared to flunarizine, only case reports and case series. Definitely the added benefit in terms of improvement in the EEG, neurocognition, and we all know that this can be effective for seizures, which is a common comorbidity for AHC. There's definite problem with administration. The patient may need to come to the hospital during initiation, and you all know about all the side effects, including growth retardation, nutritional concern, kidney stone, pancreatitis. There had been an effort to bring it in a pill form. There is a compound called triheptanion, which is a ORT chain fatty acid that would be converted to ketone in the liver. And it was studied in a randomized fashion for AHC. Unfortunately, there was a negative study. So far, we're still sticking with ketogenic diet. There had been many other medicine, and I'll again request you to refer to my previous paper. If you actually have a patient and you are thinking about starting doing some pharmacotherapy for dosing recommendation in that study. I want to briefly talk about one thing, that is intravenous immunoglobulin, that we reported our experience in the past, that when the patients are coming with the paroxysmal episodes and difficult to control, we used intravenous immunoglobulin with some success. And the one hypothesis is that as I was showing the ATP, the pump actually attaches with a hormone, anti-inflammatory hormone called OBEN, and this ATP1A3 mutation can cause problem with this anti-inflammatory hormone attaching to the pump and may produce some neuroinflammatory state, and intravenous immunoglobulin may mitigate that. And there are some studies about use of steroids such as betamethasone. As I described, the glutamate excitability, so there are some NMDA receptor antagonists that had been tried. And the one other medication that I want to mention is the ketamine for status epilepticus. So some of these patients that they would have relatively chronic but stable course in terms of their fixed neurological deficit, but then they would develop refractory or super refractory status epilepticus, and they would have catastrophic decline. And what we published from our group is use of early ketamine infusion to prevent this catastrophic decline. So that would be one medication that you may want to consider early in the treatment. So as I am an epileptologist, I want to briefly talk about this common comorbidity of ASC, who's seen more than 50% of patients with ASC. And many times they can precede their the hemiplegic episodes. But their EEG in the beginning, when they're just having the hemiplegic attacks, can be negative or just slowing, but then they would develop epileptiform discharges. They're frequently refractory or to pharmacotherapy. They are also prone to develop status epilepticus. I usually use Topomax, Topiramate, and clobazam very early in their treatment, but it's the evidence is anecdotal. No particular anti-epileptic drug may be superior to others. There is a recent study that published that other than ketogenic diet, VNS, vagal nerve stimulation, can be effective in the management of these seizures. Now, I'm almost running out of time, but I just want to say a couple things about management of other comorbidities. They would have other fixed neurological deficit. Sometimes we can be very focused managing their seizures and other paroxysmal episodes, but we need to be cognizant about managing other comorbidities, including hyperkinetic disorders, which can be very challenging to manage, and their behavioral management. Sometimes they would have migraine type of features. The last point I want to talk about that is there is also the adeno-associated virus 9 therapy that's in the horizon that had been studied in animal with reversal of their clinical symptoms with viral, including the episodic weakness. So hopefully that would come to human sphere very soon. And this is my last slide, that we know this is ultra rare neurological disease. So think about monoocular paroxysmal eye movement abnormality as early diagnostic clue. The clinical diagnosis is challenging, but if you have access to genetic testing, it can be relatively straightforward. Think about rational pharmacotherapy, and that can be feasible. And of course, research ongoing to find some sort of curative option for this rare but devastating neurological disorder. Thank you again for your attention and time.
Thank you. That was excellent presentation and a very lucid talk. Thanks a lot. And I think your take-home points are very, very, focused, and I think most concise and, to the point. I think that was very good. We have lots of questions. I think maybe 20 questions or so. I will request Dr. Jitendra to take over the question answer session.
Yes, please. Thank you. So many questions. I can begin with Andreas, I think. So Dr. Mahesh Kamthe and Dr. Brijesh Sudani has asked same question, basically about the role of SCN9A in causing epilepsy, which you have partially answered by texting, but would you, for a wider interest, would you please explain?
I'm very glad that this question was actually asked. I've just published a letter on a paper that claimed to have had an SCN9A variant associated with epilepsy. In my view, SCN9A has got no role in epilepsy. If you think about the biology, SCN9A is mainly expressed in the peripheral nervous system and dorsal root ganglia. It's got an established role in pain disorders. Yeah, so it's familial pain disorders. That's clearly has got a role there. All the literature associating SCN9A with epilepsy, none of the family histories match. And you always have other variants that might actually play a role. So SCN9A alone in epilepsy really has no role. There's a very good paper that I quoted. So this has been published quite recently, and I put that in the chat so people can look this up, by Fasham et al. So they found basically as one particular SCN9A variant that has been functionally characterized to show abnormal function in the peripheral nervous system. It was assumed to be relevant for epilepsy, but again, the penetrance of all the families wasn't convincing. And this variant was by chance found in the Amish community in many individuals who had no symptoms whatsoever. And then the authors review the entire literature on SCN9A and really illustrate that all the cases of us SCN9A with epilepsy are fraught by unclear evidence, and really so there's good evidence to show that it has no role in epilepsy.
So Dr. Vivek Jain complimented you, and he asked that in India we don't have istilpentol and also the fenfluramine. So Dr. Jain is also using potassium bromide in some of the cases and feeling some response. So what is your experience and colleagues of regarding potassium bromide in SCN1A and other sodium channel developmental epileptic encephalopathies?
Yeah, so I think it's very important. Thank you, Vivek, for that comment. It's really important. So I think in terms of the basic treatment of sodium valproate, then benzodiazepines work well, topiramate works well, and then bromide. So bromide works very well. So we have often in intractable cases where we have difficulties, we often use bromide, and we've now also giving advice to other centers in the UK to use bromide. So we've had very good experience with using bromide. And the other thing is the ketogenic diet works really well. So there's good evidence that the ketogenic diet can work in Dravet syndrome. We have been using the ketogenic diet for over 20 years in our center. We now initiate the diet almost exclusively at home, so the patients don't have to come to hospital for that. Only infants less than 1 year of age, we would do that in hospital, but for all other patients, we would do the initiation at home. So, and that's, I think the ketogenic diet is, as also the previous speaker said, is really a good option for epilepsy treatment, for refractory epilepsy treatment, and that's really something to consider, because what you need is really the nutritional aspects. So you need to have a dietitian and a lab that can actually monitor some of the the vitamins and trace elements. But that is really something to consider.
Yeah, so that makes the point. So question for Dr. Murugan. Dr. Mini is asking, what is your experience on migraine presenting as limb pain especially?
See, the migraine, at least in relevance to the hemiplegic migraine, what we talk about is the aura associated. The aura is in the form of either peripheral, pins and needles, or numbness of the limbs. That's all you can experience. Otherwise, when it comes to pain, I would say headache is the only pain one should experience. I don't think you can have it in the constant limb pain as part of a migraine phenomenon. So paresthesia and numbness could be there. That's all it can be there.
So question for Dr. Debopam by Dr. Mini. Have you come across low CSF glucose in genetic proven AHC cases?
No, I have not. Some of the patients that had been previously diagnosed clinically that I have seen had like a low CSF glucose, but I think some of these patients are just GLUT1 deficiency disorder rather than true AHC. In my practice, we are just not doing that many CSF glucose at this point. If we have clinical suspicion, we're going straight for next generation sequencing or exome sequencing.
Okay. So a question for Andreas. by Dr. Gauri Passi. She asked two questions. So first, is there any role of molecular chaperones for treatment of SCN mutations? And second, is lacosamide safe in Dravet or should be avoided?
Okay, so I think in terms of, I personally don't have any experience with a molecular chaperone treatment. I think it can be used to correct misfolding of channels, but I have no experience with this. Lacosamide is a sodium channel blocker, so I think, you know, given the disease biology, sodium channel blockers are contraindicated in loss of function SCN1A variants.
So, question for Dr. Murugan. In familial hemiplegic migraine, whether a family history of migraine with aura is enough, or family should have history of hemiplegic migraine?
The criteria I have shown is for family members should suffer with hemiplegic migraine. It is not just migraine with aura. If a family have migraine with aura, if the child develops hemiplegic migraine, that child is sporadic hemiplegic migraine. Subsequently, that family may become a familial hemiplegic migraine in the future generation. But without a hemiplegic episode in any family member, so that won't fit in with the criteria.
And another question that, although it was answered in the talks, but there seems to be so much overlap between alternating hemiplegia of childhood and familial hemiplegic migraine. What would be the absolute differentiating feature between the two? So is there any dividing line specifically?
I can take the talk. So for familial hemiplegic migraine, so half or more than half would have familial history. There are some would be, that's the first case in the family or sporadic FHM, but for AHC, it's a de novo disease. So there is no familial occurrence for AHC. And then AHC, usually you would have earlier onset usually, and they would have more complex feature. The incidence of epilepsy is much higher in AHC. FHM, if you have ATP1A2 mutation, you can have epilepsy. So that's one gray zone that some patients with ATP1A2 mutation, it's very difficult to distinguish between AHC or FHM. And sometimes you just need to have a family history to see what's going on there. But key differentiating feature is ATP1A3 mutation. So if you have that mutation, that would push towards AHC rather than FHM.
So question for Andreas. So Dr. Shrikant presented a clinical scenario in which one child with recurrent fever-triggered polymorphic seizures, and he was detected to have two heterozygous autosomal dominant inheritance genes variation in SCN1A as exon 9 and exon 13. And then the parents were tested, and the father was negative for both, and the mother was positive for, mother was carrying one variation which was exon 13 and but negative for the other exon 9 variation. So so he wants to know whether this variation, which variation, whether can be considered as pathogenic, or what is your practical advice on this type of scenario?
So whenever you have, you know, a severe phenotype such as, you know, Dravet syndrome in the child, you would expect that this would be a de novo. And in majority of cases, you would expect that this would be a de novo. So if you have two hits, you've got two variants. It doesn't specify what type of variants these are, but if you've got one variant that's inherited from a parent who's completely well, has no other symptoms, then it's very likely that this is one of those variants that I showed in my talk that happens in general population, and it is not a disease causing, or it doesn't reach a threshold that it would be disease causing. So the other variant, that's the de novo variant, appears to be from the, you know, to me would appear to be the one that's causative for the child's presentation. Sometimes you can have if you have, you know, it's a threshold effect. So you can have a variance that even in the lab you might find, oh, there's a small effect, but actually in the patient it doesn't present, but it could be contributory. But actually, I would think that the de novo variant appears to be the main variant for this child.
So Dr. Raj also complimented and wanted to ask a question that whether heterozygous variants in SCN2A or other sodium channel blockers, if gives a Dravet syndrome phenotype, what will be your appropriate strategy, sodium channel blockers and treatment all regarding?
So I think we've published a paper on Dravet mimics, where we looked at really different presentations, and that there were a number of reports in the past where children were reported to have Dravet syndrome, but not just with SCN1A variants, but with other variants. And I think this happened at a time when we didn't know so much about the other emerging phenotypes. And if you now, I think if you now go back and look at the evolution of seizures and the phenotype in those children, that we really have a core Dravet phenotype caused by SCN1A variants. I think the SCN2A variants are just very different. The children present much earlier. There's a different history to that. So these are SCN2A related epilepsies. And I think with the SCN2A related epilepsies, if they're early onset, earlier than 3 months of age, very often they gain a function, and you would try sodium channel blockers. If they're later onset, then it's much more likely that they're loss of function, and then your sodium channel blockers will not work.
On similar lines, there is a question there that there is a concept of phenotypic pleiotropy, and the same SCN1A disorder genetic variation can cause Dravet syndrome, and the milder presentation can be there, but they may have developmental and epileptic encephalopathy presentation, for example, infantile spasms. So if you diagnose a case of West syndrome or infantile spasms with underlying SCN1A pathogenetic variation, whether you would like to treat first with the hormonal therapy, or would you like to try other medications in the Dravet syndrome line?
So in SCN1A, that's so I haven't come across. So in SCN1A, I haven't come across in West syndrome. So an SCN1A loss of function child will not present like a West syndrome child. But in SCN2A that might happen. So in SCN2A, loss of function variants can present, for example, with a West syndrome presentation, and then because it's loss of, if that's loss of function or presumed loss of function, then sodium channel blockers would be difficult, and you would probably go down your routine steroids, vigabatrin choice for if it's West syndrome. So I think you really have to look at the disease biology and what makes sense. So that so there's actually good evidence from all these large cohorts, and we've got now more and more cohorts being presented with the genetic background, treatment effects. So the SCN2A study by Wolf et al. Is really informative, and you've got I think there's a new study in SCN8A coming out, also in SCN2A this year, which have really large cohorts that give further advice on what the whole spectrum of that phenotype is like and how to treat.
I think that makes sense. So question for Dr. Murugan, in a context of a familial hemiplegic migraine, on evaluation, if you find evidence of infarct, whether it rules out familial hemiplegic migraine or this is still be possible.
Okay, when you say the infarct, but I think if it is a stroke, is a primary diagnosis, and if it is convinced with the history and the MRI finding, that is a different story. But to have abnormal MRI, it could be old stroke sitting there, and the episode is not related to the MRI finding. Then you may be seeing a child with a new episode of hemiplegic migraine. So all depends on what that nature of the stroke is. If it is acute stroke, clear cut, explain the contralateral hemiparesis, and the presentation is very acute, then that's straightforward. But in a child who is suffering recurrent episodes of headache with aura already, on top of that they are experiencing, and there is no acute stroke changes, then that is kind of a different scenario. Because to have abnormal MRI could be a coincidental finding. Stroke some time ago it happened. So it all depends on, is it an acute stroke, is the history suggest it's an acute onset stroke or not. So if the MRI findings doesn't suggest, naturally there is a history of migraine with aura, and one should consider towards hemiplegic migraine.
Thank you. So there is a question by Dr. Vivek Jain for Dr. Debopam Samanta that he complimented, and he wanted to know whether you have used melatonin for acute events of AHC and whether it helped. And for prophylaxis of AHC, how long one should give ketogenic diet as the condition is lifelong condition, and in your experience when the episodes resolve with age?
Yes, so thank you for that, for both questions. Definitely, I have used melatonin. Now, I have seen benefit from melatonin. Sometimes it's very difficult to know. I usually tell parents to track or some sort of document how many episodes they're having, how many different types, and the duration. And then I start a medicine and I track over next 3 months to see. And there are some patients that have benefit and actually prevent the patient to coming to the hospital because they're sleeping. I have to use high dose melatonin. I have gone up to 10 milligram melatonin for these patients. And I have not seen any safety concern for that high dose. We don't know if the artificial sleep is as good as natural sleep, but that's what we have that I've used. Ketogenic diet, I have used it for many years. I have patients that are on the medication for ketogenic diet for 7-8 years without any problem. In general, I try on an average 2 years, and then I try to slowly wean and see what's happening, because many of these episodes are age dependent. So some of the episodes they're having when they're 2 years old may not happen when they're 5 or 6 years old. So I usually try to do a slow wean over 3 months to see if the episodes are coming back or not. And sometimes it does. I then go back to the ketogenic diet. The one concern about weaning, most of the medicine that I describe, weaning would be fine, except flunarizine, that I usually caution parents to not to do sleep self-wean, because there are some reports that with mainly from Japan that rapid weaning of flunarizine can induce catastrophic decline. Thank you for those questions.
So the next question is for Dr. Andreas by Dr. Habib Pathan. He wanted to know, like in many countries, sequencing results takes time from month, 3 months, and sometimes it is not possible even to do the sequencing. So if a child with a suspected phenotype of Dravet or similar phenotype comes to the emergency, and if one try avoid sodium channel blocker early in the course, but if those intervention fails, whether one can try sodium channel blocker empirically, or what is your suggestion on that scenario?
So I think, Dravet syndrome is a clinical diagnosis. So if the phenotype, and we know that about 10% of children do not have an SCN1A variant identified, and this might well be because it's a deep intronic variant, or we just haven't got the genetic techniques to detect them at the moment. So if you've got a clear-cut child, early presentation, febrile, hemiclonic seizures, status epilepticus, and you think this is definitely Dravet syndrome, then you should treat as such. You should definitely avoid sodium channel blockers. In chronic treatment, in acute rescue medication or emergency medication, phenytoin is often used. So we know that in the short term, for years, phenytoin, and in the UK we still use phenytoin as a short-term use for Dravet patients, and it has been helpful. But we certainly wouldn't recommend it as a long-term treatment. That clearly is contraindicated. And we're just about to start a natural history study across the entire United Kingdom for SCN1A-related epilepsies. And one of the questions we would like to answer is, in terms of those children that actually received short-term rescue medication in phenytoin, with phenytoin, for example, in the long term, do they have worse outcomes compared to those children that did not have that? But at the moment, recommendations still are, so it's if you have a child and status epilepticus and you fail to treat the status, then you can give phenytoin trying to to treat the status. Otherwise, I mean, high dose levetiracetam, IV levetiracetam, we use now more and more and more for children with Dravet syndrome, but there's still people using IV phenytoin.
Thank you. So, question for Dr. Murugan. Dr. Raj complimented, and he wants to ask whether in the undiagnosed cases of familial hemiplegic migraine, how would be their response to the usual preventive medications for migraine, and are any drugs better than other? Thoughts on the newer CGRP antagonists. Also comments on what works best in acute episodes.
Okay, I think the whole knowledge of familial hemiplegic migraine is still staying at the level of case reports coming across from the world, basically. So what we got is a multiple, very varied experience. So some drugs which are tried in Northern America were not tried in Europe. Some of them were not tried in Australia, like that. So when I read through these case reports, in terms of, I don't think one drug has a kind of any advantage or other. It is, I would say at this stage, it is the individual department, units, clinicians' preference, and they have used it. They have seen success story with it, and then they start using it more often. I think that's how it is happening. And the normal migraine prophylaxis medicines can help to prevent the headache episodes to be reduced. It may not reduce the hemiplegic episodes as much as the other drugs. So those drugs may not make a big difference. But the main difficulty is that the episodic nature, it is not very time bound, meaning like every week it happens, every month happens. In epilepsy, we do see that 4 seizures a month, 5 seizures a month, then we can see that a response once the medicine started. Here, a same child, even without medication, can stay episode free for a year or two, even longer. So you don't want to start a medication to avoid an episode which is going to happen 3 years later. So the role of medication would be for somebody is frequently experiencing hemiplegic migraine. Those are the ones. And as I said, I have put a few medications in my slide earlier, acetazolamide, and depends on if you have an identifiable mutation, sodium channel blockers, you can use it. Verapamil, you can use it. Occasionally, I have one child somehow responded well to Flunaris, which I normally use for common migraines or migraine with other things. But that child responded well. So you would get individual case experiences, but we cannot recommend this blanketly for everybody.
I think that's
second thing is about CGRP. Being a genetic origin, I don't think we haven't established even for normal inflammatory mediated familial migraine yet. And I don't think I have come across any case report somebody tried this for familial hemiplegic migraine.
I think perfect. A question for Dr. Devopam by Dr. Channa Bhagwat. How long would you advise for chronic therapy of acetazolamide in alternating hemiplegia of infancy, whether lifelong?
Usually not lifelong. As I was saying about other pharmacotherapy, usually I give a trial for a specific duration of time, mostly a couple of years, and see response and try to wean. For example, acetazolamide, I would still need to monitor their how acidotic they're becoming, their bone status, and their weight gain. So many times those would be concerned that I many times need to wean earlier than 2 to 3 years. Many times kids would not like to take this because of nausea and decreased appetite. So yeah, usually not lifelong. I would use it even the NGS is normal. That would not be like sometimes the genetic testing would come back normal. despite strong clinical suspicion. But if they're responding to the medication, I would continue that for 2 to 3 years, and then we'll try to wean and see if the episodes are coming back or not.
So thank you. So a question for Andreas by Dr. Pradeep Punakkal, whether the gain in and gain of function of sodium channelopathies are neuron specific, meaning excitatory versus inhibitory neuron specific.
Yeah, it's a very good question. So we recently published a paper on this. So what you see is that both you've got inhibitory, so you've got all sodium channels, or SCM1A, 2A, they're both expressed in inhibitory and excitatory neurons. However, it's the ratio at which they're expressed is different. Yeah. So basically you have, if you've got excitatory neurons, you've got more excitatory channels. And if you've got inhibitory, then you've got more inhibitory channels. Yeah. So they're both expressed in either excitatory and inhibitory neurons, but it's just the ratio at which they're expressed is different.
So question for Dr. Devapam. Are there instances of alternating hemiplegia migraine without having hemiparesis?
I have a little difficulty understanding this. Yeah, so definitely, if you're talking about alternating hemiplegic childhood, you can have symptoms like paroxysmal disturbances without hemiparesis. They can have quadriparesis, they can have just tonic stiffening or dystonia. Sometimes they can have just autoimmune autonomic features without hemiparesis. So that definitely that can be possible.
Question for Andreas. What is the dose of sodium channel blockers in high dose regimen for SCN2A and SCN8A epileptic encephalopathy? So okay. What is the maximum therapeutic dose?
No, I mean you go to high therapeutic doses. So you go to your maximum. So for example, for the carbamazepine or phenytoin, you would go to whichever your laboratory, whatever your levels are. And sometimes I've seen SCN8A cases, for example, where they were responsive to just very high doses of the upper limit of the therapeutic doses. Sometimes you have to go slightly beyond that. But you always have to watch for side effects. So you need to make sure that you titrate that according to side effect response. Yeah, so but it's worthwhile to really go to the highest recommended therapeutic dosing level to see an effect. If you don't see any effect at a really high dose, that's then it probably might not work. And then you have to again look at the phenotype. This is an early presentation within the first 3 months, or this is a later presentation, so it might actually then not be again a function variant, and it might be, so in that case it wouldn't respond. It might actually get worse. So clearly, and if at lower doses you come across worsening of the phenotype, then clearly it's an indication for you to say, well, actually, this might actually not be again a function variant. This might be a different variant. You get a different response, and that's why there's one paper highlighted from Henrike Heine, where you can actually estimate whether your variant is again a loss of function variant. That's really, I think that's clinically very useful to try that. It's freely available, and you can just enter your variant, and it estimates whether this might be again a loss of function variant.
And there was one more question, Andreas, by Annapurna, whether SCN2A associated movement disorders and also gut dystopia, any specific drug or treatment options?
Yeah, so I've had a number of these patients. That's really tricky. It's really difficult. So these are often patients with very significant movement disorder and also gut involvement. So if you think about the disease biology again, so if you treat your epilepsy, and this often can have an effect generally how the child does, but if it's a question about subsequent gut dystonia, that is often very difficult to treat, and it really is trial and error. It's like with many children with profound neurological disorders who present also with gut dystonia, you have there's no set recipe to how to treat that.
Question for Dr. Devapam, whether flunarizine can be used, how early, whether even some diagnosed HC at the 2 months of age, whether the flunarizine can be tried, and what is the safety profile at that age, and what maximum dose can be used?
Yeah, it can be used even in infants. Usually, it maybe needs to start it like every other day. Some people have used flunarizine blood concentration, but it's not clear if the blood concentration and the clinical response equivalent or not. So most people would not do the flunarizine drug level. You can titrate the dose according to the response, and you can refer back to the paper in terms of the dosing recommendation for flunarizine. But you can go up to 20 milligram daily easily to manage symptoms.
Okay. So Dr. Gauri Basi and a lot of attendees have sent compliments for all panelists, and it was with this, I think we end all the questions. Yes, Dr. Ann. Yes, please.
One last comment, if I may be permitted.
Yes, please. Dr. Ann.
Dr. Brunklas, you had said this thing about bromide. So this thing with bromide, I think Dr. Vivek also raised this thing that some medicines are difficult to access in India, but we have been in certain cities. So I live in a bigger city, so it is possible for me to access tiripentol. But bromide is something we're all a little bit scared of because veterinarians use it more. So I must confess that I'm a bit scared of using bromides. Number one. Number two, when you're talking about sodium channel blockers, we don't have the ability to measure the levels for all of them. So we have the ability to measure phenytoin, but we don't have the ability to measure carbamazepine. So I remember traditionally being taught that 10 to 15 milligrams. Would you go beyond that?
So for carbamazepine, I would go. You can go to 20 per kilo per day, and you can even go beyond that. So, but I mean, 20 per kilo per day would normally be where you would, that would be your maximum for carbamazepine. And then you would, if you go to the higher ranges, of course, you look for clinical side effects. So if you are on 50,
I'm scared of them seeing colorful halos of light and puking and looking sick.
Well, but if you these kids normally are quite, I mean, if you've got an SCN2A or 8A encephalopathy, I mean, you're quite sick. So you're in a desperate, these kids have got profound neurodisability, and you are, with the back against the wall in terms of constant seizures, and that's really, really difficult. So I think if you go,
they may not even be able to tell us about their side effects.
No, but you then monitor on on observation, and I think 20 per kilo, definitely up 20 per kilo. You can go beyond that. I've got colleagues who go up to 25-30 per kilo of carbamazepine, but you have to watch for side effects. And what you can do, you want to make based on other tests, liver function, other tests, just to make sure that is not impaired. And for phenytoin, that's so that this is what you can use, and you can measure that. And as you know, with phenytoin, often you get to a point and then suddenly you get into the toxicity range, and then you have to scale back. So it really is, you have do that slowly, and then watch for side effects. And if there's no obvious benefit to the patient, then I wouldn't keep on giving very, very high doses when there actually is not a benefit.
So it's also interesting to. Yeah, sorry.
Just go, but I would, but in those cases, because these are really intractable epilepsies, SN2A, 8 encephalopathies are really, these are difficult to treat. And it is definitely worthwhile to go to high levels, see whether A, causes benefit, B, not causing side effects. And then if it works, then I would continue. If there's no effect, then there's probably no point in continuing.
So it's really interesting to see the philosophy of care. So Dr. Samantha is from the US. You're talking from the UK perspective, and I personally was trained in the UK. The way ketogenic diet is done. I remember when I was in the later part of 2000, I was trained in the same place as Andreas in pediatrics. At that time, we used to admit patients for ketogenic diet. And when I started neurology, we no longer admitted patients. So I follow the same principle. We no longer admit patients for ketogenic diet. We just do it, and we're used to doing it because we have really good dietitian services, and we have a lot of children so we're comfortable using ketogenic diet. But that also depends on the sort of dietitian services that's available, which is variable. We hope that those can be scaled up. But thank you for giving us different.
I think, but on that note, what's interesting is that now with the pandemic, and also I know that when there's different surveys across the world, how the care for children has changed with epilepsy. That, for example, in the past, lots of centers would admit children with infantile spasms to hospital to commence treatment, and now that's changed because you didn't want to bring children into hospital, so you actually manage them at home. Yeah, so I think there's been lots of changes where you realize you don't have to admit children to hospital to start certain treatments, and it's safe to do that in the outpatient setting.
Okay, thank you very much to our wonderful moderators, Dr. Sahu and Dr. Aneja, and to our wonderful speakers. We've got really great feedback. Not only the feedback that you people have got here, I've been complimented because of the three of you. So thank you very much for a fantastic job, all three of you. Everyone has been very, very happy. Thanks for taking the time. And we're inviting all the others for the next talk. This was a very concentrated topic on channelopathies. The same way we have some fantastic speakers for our next session, which is on neurotransmitter disorders. We've got people who are doing cutting edge research like Professor Manju Kurian and Joanne Ng, along with somebody who does a lot of work in India, Dr. Sangeeta from CMC Vellore, as well as the moderators are also like Dr. Sahu, who's doing a lot of work with sodium channelopathy. Dr. Urani does a lot of movement disorder work with Dr. Alpade Rai, who has set up the first lab in the country which can measure neurotransmitters. So please feel free to share the flyer and join us if you can. Thank you so much. Thanks to ORDI and AOCN for arranging this. Thank you.
Thank you.
Thank you very much.
Thank you.
Thank you.
Thanks.
Bye.
Bye.